Welcome everybody to the August program of Caring and Coping series put on by the Roosevelt Alzheimer's and Dementia Community Action Plan. We thought that this topic was particularly important. So today we'll be talking about hospice care for persons with dementia, and I've invited 3 panelists that come from the world of hospice with varying experiences to come answer some most common questions, and then at the end there'll be a time for you, the audience, to ask questions that may have gone left unanswered. I would also like to say that the Minnesota Network of Hospice and Palliative Care, they meant to be here today but were unexpectedly unavailable to come. So I did print out some of their guides that you are welcome to take, and their website has more information about hospice and palliative care. And then some of our panelists have brought things from their organizations along as well. So I'm Sam Stingman. I'm the executive director of Big Community Nurse Network. I'll be the moderator today, and I'm going to let each panelist introduce themselves and just give a brief summary of who they are, why they're here. Jen?
All right. I'm Pastor Jen Johnson. I'm a chaplain with Optage Hospice, which is a division of Presbyterian Homes. This chaplaincy was a complete career change for me about 5 years after my mom died, and we had a really lovely hospice experience. I felt this calling and went to seminary and got a master's of divinity, and have been now working as a hospice chaplain for the last 8 years for Optage.
Jim?
And my name is Jim Hymans, and I am with Ecumen Hospice. I'm one of the bereavement coordinators with Ecumen Hospice. I've been doing hospice since 2001. I was trained as a psychotherapist and met somebody at a conference about death and dying, and just fell in love with the idea of openly talking about death and dying and grief and loss. And it's been a home ever since. I'm trained as a clinical social worker, so I worked as a hospice social worker in the field and in management, and then transferred into bereavement coordination just in the last couple of years.
Thank you. And yeah.
Yeah, good afternoon, everybody. Good to be with you all. You can call me Neil or Dr. Budenseek or Dr. B. Usually call me Dr. B. I'm formerly an internal medicine physician, so someone that takes care of older adults in all of the general and very also specific ways. I specialize in areas of people living in nursing homes, assisted livings, hospice care. I'm a certified hospice medical director. I'm a certified nursing home medical director, a certified wound care specialist, and I also do some medical legal work nationally. So I've been in the field for about 18 plus years, and love the most challenging people and challenging symptoms to try to provide comfort and support each and every day of their life. So just looking forward to the dialogue today.
Excellent. Thank you all. So I'm going to pose kind of a category and some underlying questions, and then I will have each of the panelists share their take on that topic. I am realizing that I'm not a great moderator, and I forgot to bring my document that has which order you all are supposed to go in. So, you have it? So,
Dr. B first.
Yeah. So I will try to do my best to remind to direct who goes first, but we'll just play it by ear. So the first thing we're going to talk about is the basics. What is hospice exactly? What is it not? And then kind of the difference between hospice and palliative care, and which one might be better for persons living with dementia. I think I have Dr. B going first
Yeah.
for this.
Thanks, Sam. This is a 30,000 foot question, and we're going to zero in a little bit more as we go through the afternoon here. How many of you know or have heard of Patch Adams? Patch Adams. Okay, so many of you. If you haven't seen the movie Patch Adams, you may want to after we're done today. I think trying to put it visually into an expression of what palliative care is. There are many definitions of palliative care. I'll share a couple of them, but Patch Adams, I think, really said it best when, in the movie and in his life, he said, you treat a disease, you win, you lose. But you treat a person, I guarantee you'll win no matter what the outcome. And it really is about focusing on the humanity, the person before us. And unfortunately, a lot of times in healthcare, we almost forget that, or we think of something beyond that when we need to start with the person. So the World Health Organization has a definition of palliative care that to me is fairly complicated, and then I'm going to share what I really would like to believe is the most simple and easily rememberable palliative care definition. But the World Health Organization has a definition that palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. That is a very large mouthful. Essentially, it's the best care. And palliative care, when we begin to juxtapose it or contrast it to hospice care, what comes to mind for me is either way, whether it's palliative care or hospice care, it's the best care for you and your family at the particular age of your life, because palliative care and hospice care apply to all ages. I mean, there are people in palliative care that are 2 years old, 20 years old, 90 years old. There are people in hospice, unfortunately, that are 2 years old, that are 20 years old, that are 90 years old. But the difference is the stage of the illness. So palliative care and hospice care, it's for all ages. But palliative care is a specific stage, as is hospice care is a specific stage. Hospice care is the stage of end of life, as we call it. Now, it's hard to prognosticate. It's hard to know if you're at that stage. But as we best try to do, we try to prognose. We try to give you an estimate of what your length of life is still to be. And if you're in that end of life phase and stage, then you would be into a hospice type of experience if you don't want to continue curative care. And that term, depends on what you're dealing with. Alzheimer's disease, other neurodegenerative diseases, Parkinson's, frontal temporal dementia, people with a mixed dementia that they're living with strokes and Alzheimer's. A lot of those we really don't have a cure for. So it's a chronic disease. And so palliative care is very appropriate for all those people. But when you're in that end of life stage, no matter what your age, then hospice is a very good option. And so that's the type of thing to keep in mind, is that it's holistic, and we're going to go into that more too. I think we have a great infographic there. And so palliative care is not just preparing for death. It isn't. You're trying to live the best life you can. You're wanting curative means or curative treatments, but you're also trying to enhance and to elevate your quality of life. Nothing better than to utilize, when it's available, palliative care. One other way to look at the difference between palliative care and hospice that I share is hospice is not palliative care in one sense, because it's a different stage of life. However, it does incorporate all of the principles and the philosophy of palliative care. So hospice is not palliative care, in that sense. But it is very much the same philosophy of care. And I think that's where we get tripped up a lot. And then you have sometimes, and I'm not political, but then you have death panels talked about. You have all these different terms. And I think the greatest thing right now is with former President Jimmy Carter and Rosalind Carter being able to be really exemplary. And I think we need to bring that out today, is that is a great expression of the beauty and the really great things about living your fullest life, but also at a certain stage of life, being able to pivot to a comfort hospice approach. I'll stop there for now, and I'd welcome our other panels.
Okay.
So I think one of the questions too was what hospice is not, correct? And a lot of people just think that you sign the paperwork for hospice and you're dead in 2 days or 6 hours or whatever. That might be the case sometimes, but the ideal situation with hospice is having that early referral, and we'll talk a little bit more about that later too, so that you have time to really have full advantage of music therapy, massage therapy, your chaplain, your social worker, the hospice nurse, and just have these additional people around you. So a lot of times, and I think in the beginning stages, hospice really was much shorter. Now we have people that are on hospice for 3 months, 6 months, sometimes 18 months if it's a very slow progressing disease, and we're able to recertify them each time the cert period ends. So it is not something where, you know, the kind of the old thought process of I sign the paperwork and I'm dead, or they're just gonna drug me, shoot me full of morphine, and boom, I'll be gone. So I think there are a lot of people that still have kind of that idea, but really it's just about living your last days very fully with as much care and comfort around you as you can possibly have.
Yeah, I would echo what both my colleagues say, and it is about the disease progression, that at some point some of us are going to be associated with some sort of disease, and that disease is going to progress. And it's about that disease progression when palliative care is most needed to address those symptoms, live that life, and remain comfortable as possible, and to seek cures. It's when that time comes when are the cures any more helpful? Are what we're doing any more helpful? Because this disease is going to progress. Now as this disease progresses and the cures are no longer helpful, now we move into that hospice care. And the term that I like to use is, if this disease follows its normal course, will there be a limited life expectancy? And our esteemed doctors take a look at every which way they can about our families and patients, and sometimes determine that yes, it looks like that if this follows its normal course, there is a limited life expectancy. Now we've made that bit of a turn. At the same time, we continue with that palliative approach, where we are managing symptoms, we're making life as livable and as symptom-free as possible in the light of this disease progression.
Thank you.
I think to echo one other thing is that when you look at that timeline, and obviously on the left side, or maybe not so obviously, is you being born.
Yeah.
And then right before it pivots from death to bereavement, we don't want to forget the value of that post-death bereavement support for family. And that's really not a part of palliative care in the formal sense of it, because you're not at that end of life and you're not going to, more likely than not, die. You know, it's a period of time where that's just as important, if not more important, for the family. And some families welcome that bereavement support more. Others have community resources, or friends or family or religious communities, or other communities that help them in that period. But the bereavement obviously is specifically more towards the hospice episode.
Thank you. And now we're going to spend a little bit more time talking about what does life with hospice look like. Some myths that people come on board with hospice, and being enrolled in hospice, what that means, and then what the reality actually might look like. And I have one of you two starting first.
Me.
All right.
Yeah, and Jen mentioned it before, that the myth of what hospice was, when I first started, it was just transitioning more into home care base, where it used to be hospice, you'd go somewhere, you'd go to a hospice wing of a hospital. So that's a lot of the questions we get from families is, do we have to go somewhere? Can we stay at home? And that's the beauty of this program now, that the person on hospice and the family gets to choose where that person resides. What that looks like is, when somebody is determined to have that limited life expectancy, they are given the option to choose hospice care. Hospice care is a volunteer program, and then once somebody chooses that, it is paid fully by Medicare. And how I kind of explain it, we can go into this later, is we remove the hospital benefit and put in the hospice benefit. So all the care will be brought to the person instead of the person going out for care. You'd be in facilities. There's a doctor on site, usually a physician assistant or a doctor that rounds on residents regularly. They become part of the hospice team. What we do in the homes, we have a medical director that oversees our hospice team. And the hospice team consists of a nurse case manager, and that's an important term because that person manages that symptom control and comfort for that person. They are associated with an aide that comes out to the house or to the facility to help with extra cares. And then there's the other services such as social work, chaplain, music and massage, and volunteer services. So a little bit about what we do is, another myth is that hospice comes in and takes over care. We don't. We are a visiting service. So our visits are maybe 1 to 2 hours a time. A nurse would be 1 to 2 times a week. If more nurse visits are needed because of symptom management, that can be increased. Same with the aides. It's 1 to 2 times a week, more as needed, but maybe 1 to 2 hours. Social worker is there to help. You know, we work with people on this journey all the time. This may be your first time. So the social worker talks about, and the chaplain talks about, how are we incorporating this into our life? What is the life review? What is the, I can't think of the term right now, but we also look at, we talked about the bereavement afterwards, as we start working with people of, how is it going to be after this person passes? What is your bereavement journey going to look like? What kind of supports do you have in place? What kind of thoughts have you had about where to be or where to live? We kind of start working on that grief counseling as soon as hospice starts. Chaplaincy is not only about spirituality, but about, again, life review and other questions about otherworldly things. Music and massage, they're all trained, certified in symptom management. It's beautiful to hear them talk about how music can help reduce symptoms and reduce anxiety, and as well as massage. Who doesn't all want a massage? I try to visit at the same time as a massage therapist, but it never works. And then volunteer services. We try to have available volunteer services that can come into the home, so maybe the caregiver can get a break or some socialization that they might need. So to look at it, it's kind of an extra level of care in the facility. If the person resides in a facility, we don't take away care or take over, assume the care. And in the home, it's kind of that safety net. You have someone to call, someone to reach out to with any kind of question or concern of what's happening with our course of care.
I'm going to stop you right there,
Thank
and then
you.
I'm going to throw it to Jen.
I think that was very thorough.
Oh.
Yeah, that was great. That did give a really nice overview of what it looks like to be on hospice, just additional services coming in. I think the main myth, again, is that a lot of times people will say, oh, well, when my loved one's on hospice, then you'll be here all the time. Somebody will always be here, and that's not the case. As was mentioned, just it's our services in addition to whatever the facility is providing or the family is providing, depending upon where the person lives.
Dr. B?
A couple of the myths that I've encountered as a hospice medical director is, number one, people believe, whether it's the person enrolling in hospice or the family, that you have to, at that point, be a do not resuscitate, meaning do not have CPR. Now, that might seem odd, but it's not an eligibility requirement to enroll in hospice. You don't have to sign away from full resuscitation to do not resuscitate. Now, keeping that in mind, over time, typically, that will evolve to converting to or switching to a do not resuscitate. But that's absolutely not an eligibility requirement. So we do from time to time enroll people in hospice that are still full resuscitation, that they do want CPR. There is a bit of a delicacy when you're talking about, I want to be full resuscitation, but you want curative care, you know? So if something happens and you're living at home and your family is around, because they're the primary caregiver and we enroll you in hospice, if something happens, are you going to want to reflexively go back to the hospital? That's where it gets a little bit more gray, and you have to delicately manage that. But getting back to the code status thing, it's absolutely a myth that you do not have to be DNR at that time. I think the one other thing that I see commonly is that, that there's this sort of, you start, enroll in hospice, and you start getting medicated. The only reason to be medicated, as well as non-medicated, comforted from the non-pharmacologic interventions, the music therapy, the massage therapy, you name it, aromatherapy, is if you're in pain, okay? So it doesn't mean that we're gonna start medicating you with medications the moment you enroll in hospice. If there are unmet pain needs, such as physical pain, emotional pain, you may have some value in talking about a certain medication that might be useful to calm that down, to dampen that down, to mitigate that, or even potentially extinguish the pain completely. But it's usually it's a transition. The one other thing also is, if by chance one of your loved ones is moving back to the state of Minnesota and they were not here before and they don't have a primary care provider, the hospice medical director can become the primary care provider as well. So it doesn't mean if you don't have someone as a clinic doctor or a primary care provider that you can't enroll in hospice. Now, of course, we like to get the referral to hospice to have them evaluated, but as a medical director, I can be both the primary care doctor and the hospice doctor. Okay, so that shouldn't ever be a barrier also.
Next, we're going to stay with Dr. B, and we're going to talk about appropriate medications. Some questions that I was asked when we started planning this were, can dementia patients continue medications related to dementia after going on to hospice? And also to speak to what to consider about the use of drugs hospice frequently uses for that pain and agitation that might exacerbate dementia symptoms.
So, would you mind going back to, I want to actually go back to the infographic about the different types of dementia, just so we can we can, because this is sort of 30,000 foot too, and I know a lot of people, it's almost a myth, I could say that. You have a diagnosis of dementia. And really the term dementia is an umbrella term, and so it's not a diagnosis. You want to look at then what is the type of dementia, right? So when anybody says, especially for people that are seeing many different forms of neurocognitive impairment and decline, which can be upwards of over 120 different types of dementia, actually. Although we know the most common ones there, Alzheimer's disease being the most common. You can think of these types of dementia as the raindrops, so to speak. So you have the umbrella, which is the term used for neurocognitive impairment or neurodegenerative conditions. And then within that, you have the raindrops, which is most commonly Alzheimer's disease. Next most common is vascular dementia, which is people have had strokes. A lot of times they may have mixed dementia, whether that be a combination of Alzheimer's disease and vascular dementia. And then we have the people living with Parkinson's disease, and they may have dementia with Lewy bodies, or they might have Parkinson's disease with dementia. It just depends on which part of that equation actually starts first in their life journey. And then we have FTD, which is frontal temporal dementia. Frontal temporal dementia, more common in people that are in their 50s, 60s. You can have people with Alzheimer's that are early onset Alzheimer's in their 40s even, or 50s. And then you get into these much more rare things like Creutzfeldt-Jakob disease, mad cow disease. And I actually have had one person that we found out that they had Creutzfeldt-Jakob after we enrolled them in hospice. They didn't know what the diagnosis was, and then came back the cerebral spinal fluid results. It was quite a remarkable thing to have to talk to them about that. We don't know how they got it. And then, so just to get that as sort of a framework for you when we're talking about dementia, we're really not talking about dementia as a diagnosis, but as a umbrella term. Let's go now to this is where I have great joy and fun because of being a clinician, and I could geek out on this for many, many hours, but I'm not going to. But these would probably, perhaps, and we would welcome your questions as we go along, the most common types of medications that initially people have been put on historically if you're living with Alzheimer's. So if you're living with Alzheimer's, you probably were on or are on one of these what's called acetylcholinesterase inhibitors, whether that's donepezil, which is known as Aricept, rigmastine, which is Exelon, it's a patch, and then galantamine. These, which is Namenda, these different types of medications to try to enhance cognition, to reduce the decline before you become institutionalized or before you are at sort of severe stages of dementia. Can be helpful, but not very helpful. They're much oversold by drug companies, and I think more and more we realize, unfortunately, they don't work that well. But they do provide maybe a few weeks or months of better cognitive function and functional, like doing activities of daily living, such as your normal types of what you do every day, just bathing or hygiene or ambulating or eating or cooking or using pen and paper for finances and stuff. So anyways, usually we will, in hospice, not cover, this is where the rub is sometimes. So different hospices, and I'm not talking about a for-profit versus a not-for-profit versus a governmental hospice, but different hospices have a little different philosophy about whether they're going to, quote, cover certain medications. And what that means is that they will eat the cost of that medication versus they won't eat the cost because they don't think it's helpful for your comfort, okay? When it's not helpful for your comfort, then what hospices often do will say, we're not going to cover this. And then they have to give you a sheet of a document that says these are the meds we're not going to cover, because then you're on the hook for covering them as far as cost, okay? But typically, the donepezil especially, and I've seen this over and over again, it's very common in the medical literature also, is that people that are not eating well and they're getting more and more malnourished, and they're living with Alzheimer's, the first thing that should be done, even before they enroll in hospice, is tapering off the donepezil, tapering off the Aricept, because sometimes that causes gastrointestinal effects. And I've actually, been able to graduate somebody from just getting off of their Aricept. It's striking. It doesn't work for everybody, but that's something to keep in mind. At a certain point, you don't want them on that fence anymore. You want them to be, unfortunately, on one side of the fence or the other, and sometimes it causes more harm or adverse issues with eating and behavioral expressions like agitation and restlessness than it's worth. So usually we will recommend discontinuing them, tapering them off, giving them a drug holiday, as we say, and seeing if they do just as well, if not better, off of those drugs. So that is one thing I would really strongly file away, because those often are the ones we will recommend discontinuing. And occasionally they help enough where you actually graduate from hospice. Okay, sort of odd, paradoxical. But what we also know about certain drugs that are the common ones that you might think about as being in like the comfort kit. The comfort kit. If you are residing in a private residence, let's say for example, quite often the hospice will have a comfort kit that will have various medications. Sometimes those medications include what is a class called benzodiazepines, lorazepam, which is Ativan, alprazolam, which is Xanax, clonazepam, which is clonazepam, and or Klonopin. Also opioids, meaning narcotics, morphine, oxycodone, hydromorphone is called Dilaudid as well, or antipsychotics, okay, haloperidol, risperidol, olanzapine, quintiapine, Seroquel, Zyprexa. These are different comfort meds that can be used, or they can be used inappropriately. What I would challenge many times, and I've seen this again, a lot of this is anecdotal, a lot of it is based on geriatric types of medical literature, which not all hospice directors know. I actually took over once for a hospice medical director. I'm not trying to be nasty, but he was a vascular surgeon. That might not be, it could be the best doctor in that position, but it may not be. Sometimes hospices are challenged to find doctors that want to be hospice medical directors. And sometimes they don't know what they don't know. So being very humble about that is, but benzodiazepines are really almost all the time until you're really end, like actively dying, and you want to really help them calm down. You usually don't want to use benzodiazepines in people living with various types of dementia. Okay, and that's pretty overall. Carte blanche is very common that I'll see people increase risks of falls, or they're falling, they're getting delirious and more confused. Those types of meds in the benzodiazepine class act no differently in the brain than drinking alcohol. Okay, so if you think about, maybe I can still remember this unfortunately in college, when my roommate decided to stand up in the middle of my resident hall and do something, he didn't remember it the next day. Sometimes these benzodiazepines really cause issues with behaviors, and sometimes they can actually paradoxically cause hostility, emotional aggravation. They can get very physical. So the point is, I would just be very cautious that I typically don't prescribe for people living with various dementias the benzodiazepines. It's not to say in other conditions they can be very useful, whether that's in chronic anxiety, people with seizure disorders, people with a lot of muscle spasm issues. I mean, they're muscle relaxants and anti-anxiety meds too. But opioid-wise, typically, I've had some, even cardiology sons and daughters, they think that 5 milligrams of morphine is going to put their loved one completely out and kill them. We want to start low and go slow, right? But typically 5 milligrams of morphine, which is a very slow dose, will not cause a lot of great sedation issues, and it certainly won't take away their drive to breathe. But most of the opioids overall, do pretty well. There are certain conditions when you're not talking about people living with dementia, but people living with chronic kidney issues that are really advanced, or chronic liver issues where you have to be a little more concerned about which particular opioid you use. But overall, probably the drug of choice is the liquid morphine. And then occasionally, if I have someone that's not tolerating the morphine, I will switch to the hydromorphone, because anecdotally, the hydromorphone maybe has less effect on the brain and you might tolerate it a little bit better. So just something to keep in mind, that you could switch to a different opioid. If you're seeing some maybe cause and effect, you give it and within an hour, you have behavioral expressions that suddenly are really logically connected. And then lastly, the antipsychotics. Those are the ones I go to more often. If I'm needing anything to calm and comfort, and it's due to anxiety or aggravation. Not the benzodiazepines, which can make things worse, but rather the calming antipsychotics. And again, each one is a little unique. The Seroquel or the quintiapine on the end is the more sedating. And then when you go more to the risperidol, it's not as sedating, a little more just calming overall. Haldol is still really the drug of choice most of the time. And in the short term, and at lower dose, I find that works pretty well. It can be liquid as well. So a lot of times you think about these drugs as, do they come in a non-tablet form, or a form that can be crushed, or a form that's liquid? You hate to use suppository or per rectum if you don't have to. So that's a lot of the sort of behind the scenes that goes on with some of these drugs. But just things to keep in mind. Again, each case is specific and different, but some generalities that might be worth considering. If you're seeing bad effects, or effects that you're like, I think this is related because it's within an hour or two of the drug being given. So, all right, I'll stop there.
Thank you. Anything to add, Jim?
Well, I do have a couple of things, and I'm glad you didn't geek out on it, and like you thought you might. That was really helpful. I think two things. One, when someone is eligible for hospice and they're on that transition where their body is changing, and how we kind of talk about it is it's transitioning towards end of life. The body is starting to shut down naturally. Medications like what Dr. B was talking about are going to affect me different than it is somebody who's in a debilitated state. There's things that need to be addressed when somebody's in a debilitated state, and it works differently, and it's helpful. Secondly, with the dementia component, that you and I know that when we're not feeling well, I'm not feeling well, I need something, I need to take something, do something, you can talk it out and explain it. When a person is dealing with or living with dementia, that mind-body connection isn't there. So it's hard for them to express, I'm not feeling well, or to understand why I'm not feeling well. And that's where these medications then come helpful as well, because they're not able to express it, and we can kind of watch things, we know something's not right, that these are helpful to address those things. So I appreciate you explaining it. That's the two pieces I have.
And I would just add, a lot of times, again, the myth is that people think, oh, they're just going to give my loved one so much morphine that they're not going to be able to communicate. And it is always such a low dose to start with, and then slowly increasing. So people always use the word snowed. Are you going to snow him? It's like, no, not at all. But this is going to help with the breathing, relax a little bit. And sometimes there is just pain with transfers. And if we can avoid that pain before that person is moved and stay on top of that, from their bed to getting dressed to the wheelchair in the morning, they're going to have so much more of a better day if they've got a little something for comfort for that, than if they are just in extreme pain for 20 minutes while that transfer and changing is happening. Then it's hard to come back from that.
What also came to mind was we don't want to forget about sort of our core or sort of fundamental qualities as humans. Are we, may not sound great, but are we pooping regularly? Are we constipated? That could cause behavioral expressions. So oftentimes we'll have a bowel stimulant or a bowel softener that's being given, whether or not they're on an opioid or not, just to make sure that the bowels are going okay. We don't want diarrhea, of course, or loose, but We don't want any constipation, which can cause aggravation of people living with dementia often, because they can't say they're constipated. I think the other thing is, are they emptying their bladder okay, right? Because sometimes urinary retention actually will cause behavioral expressions when it's not found out. A lot of hospices don't have the bladder scanners, so you're sort of stuck with maybe having to do a catheterization once in and out, just to make sure you know after they've gone to the toilet whether they're retaining. And you hate to put a catheter in because it's a foreign object, right? Anything that someone living with dementia has that's not normal in their body or around their body is going to be at risk of being pulled at or ripped out. And so we try to avoid at all costs using catheters and various types of tubes unless we really need them. So a couple other things to think about. Again, non-pharmacologic. Make sure the bowels are working, make sure the bladder is working, and make sure that there aren't meds that they're on that are actually contributing as well to behavioral expression.
Now we're gonna jump back. We've mentioned enrollment a couple times, but to talk more to that, how does one get enrolled in hospice? How is eligibility determined? Who actually makes the referral? And is there a difference if I wanted to enroll in one hospice versus another hospice, or is enrollment pretty standard across providers?
On that one, it is you.
Oh. So I'm going to pull the curtain back as the great Oz here, so to speak. I mean, most of my work as a hospice medical director around hospice eligibility is data driven. It's really data driven. And what I've seen is the robustness or the lack of rigor in getting as much data as possible from the family, the patient, if they're in an institutional setting, from the facility nurse, the team there, and that nurse then there, that care manager, grabbing all that data and being able to put it into a palatable form that I, as the human, the medical director, can then digest. If I don't have all that information, I may inadvertently say you're not eligible. Okay? Now, what is that information? What is that crucial information? I mean, if I could have certain things on a silver platter, which sometimes I get, is what is their weight trajectory? You know, what was their weight 6 months ago, a year ago, last week, or today? How many hospitalizations have they had in the last 6 months? How many emergency room visits have they had in the last 6 months? What were they for? What did their subspecialists say about their cancer? What types of treatment options did they have or didn't have? What did they decide to do? Again, nothing about code status, right? But a lot of that is then also around activities of daily living. How are they eating? What's their intake? That connects to weight. What is their typical day like as far as mobility? Are they ambulating with a walker? Are they ambulating by using a wheelchair? Are they just walking? There are actually a couple different scales that you can go online and you can figure out yourself what data is helpful. And one of them is called the Palliative Performance Scale. Palliative Performance Scale, PPS. And the other one for people living with Alzheimer's is called the FAST, F-A-S-T, the Functional Assessment Staging Tool. And both of these, historically, the PPS for people living with various cancers, it helped with prognostication. And usually that has to do with, are they losing weight? Are they getting malnourished? Are they getting functional decline? And that helps you really understand where they're at as far as their prognosis, if they have 6 months or less to live. There are certain criteria that Medicare actually requires us as hospice medical directors to document. And so we will be asking, the nurse, do you have a FAST for someone living with Alzheimer's? Do you have the PPS? Usually there's a lingo, there's a language to what we talk about, but it all comes from activities of daily living. It comes from your level of consciousness or wakefulness. It comes from how's your intake been, what's your weight trend. A lot of those things will help paint the picture. We talk a lot about painting the picture, and if we don't paint the full picture, you're going to be left with a hospice that may say to your loved one or you're not eligible. That might not be totally true. That's why sometimes it's actually, and I sort of get interested and excited about this, is when a hospice has declined a person for hospice and another hospice looks at them as well. It can go both ways though. Sometimes hospices, the medical director's a little more lenient, sometimes they're a little less lenient, sometimes they didn't all have the same data to work with. So bottom line is, if the hospice eligibility is declined, you're not eligible, it's good to say, what information do you have? Because I may be able to help paint the picture better for you than what you currently have. And that's golden. That helps really us all try to work together.
I would just want to add on to that. I so appreciate that. And, for someone, when a doctor thinks, this person may be eligible for hospice, would you like us to make a referral to hospice? Then it comes to us and we set a plan to meet with the family, and we'll do a consultation before an enrollment. And what's helpful is by that time, we've gotten permission to look in the medical record to see what those things are hitting, if we're hitting and seeing that decline. But what's more valuable is to go and talk with the family and the patient, prospective patient, and say, what have you seen over the last 6 months? What changes have you seen? It helps paint that picture of, I've just had to change his pants more often, or he's not able to get in the car as much as before. We can start help painting that picture, which then maybe tips that over to eligibility from the medical director, saying, yes, now it looks like there is more decline. Because we're kind of looking at how I kind of explained with families is we're going to look at the last 6 months to a year. What changes have happened over those last 6 months? If those changes continue to happen through the disease course, is there limited life expectancy for the next 6 months? So we kind of do a look back and then project the future. But that observation from the family and the stories of the family is just so helpful to have, because that we don't get that on the medical side.
And dementia itself typically isn't, what's going to be enough, but you're going to be looking for dementia plus. Now they've had 4 falls in the last 4 weeks, or they've had, because someone can live a very long time with dementia, but it's going to be those other changes that you start to see along with that.
Yeah, I've said that to families. Dementia is not always a terminal diagnosis. It's not a terminal disease. It's the complications that come with dementia that is the terminal part.
Yeah, and there are some times where I've found nothing or not enough, and so then if you have a hospice that's asking for labs, which I rarely get, but if I'm trying to get your loved one on and enrolled, the types of labs that I use as sort of a last resort, if I don't think the story is compelling enough yet, is we'll get a nutritional marker, although for what it's worth, it's not in any stretch of the imagination that this albumin level is like a slam dunk that you're malnourished. But the point is that is one of the criteria that Medicare uses, that as long as you have a albumin of less than 2.5, okay? That means that you are eligible for hospice under that protein calorie malnutrition diagnosis, okay? For people living with advanced kidney disease, good to know what the kidney function tests are, what the electrolytes are. For someone with liver disease, what's their liver function? So there are times where in certain diagnoses, if we're gonna have them as the primary rather than the secondary, the primary is the one that leads the way into hospice essentially, is there are some conditions, some diseases that require more heaviness on the lab side than other ones. Typically the ones around the neurocognitive impairment, neurodegenerative ones, like all those dementias, are more functional, nutritional. How many times you've been into the hospital, in the ER, that you've fallen? Have you broken a hip? I mean, the hip break is really, it helps. It's not a terminal diagnosis, but people that break their hip, unfortunately, and it's not because of a high energy motor vehicle accident, but just a fall from walking or bed, 50% or more are terminal. And we see that a lot of times, obviously. So that does help paint the picture. They broke their hip in the last 3 months. So.
Someone mentioned it earlier, graduating from hospice. I know that before I came to the hospice field, I didn't know this term. So I thought that maybe we could talk a little bit about graduation and why would someone graduate from hospice and what that might look like.
Well, it is Dr. B again.
Well, I'm going to get slightly statistical here because I think that will help you. And this is actually from 2022. We don't have anything from last year yet, but the National Hospice Palliative Care Organization has. You can go on their website, National Hospice Palliative Care, and they have a 2023 edition, which is up through 2022. So, rates of hospice live discharges. What a great term, live discharges. Well, I mean, essentially that's your graduating. Now, that isn't everything, but on average, all live discharges in 2021, because this is data from late 2021, is around 17% of people are a live discharge, okay? So that means either that the natural course was a different trajectory of decline than what was thought to be the natural course of decline. That also means that an individual or a family could have what we call revoked hospice. They decided to disenroll. So that's actually included in some of the live discharge information. Also, if they moved out of the service area, so hospices have a certain service area. And so if you move out of that service area, they have to discharge you. Now, that doesn't mean you might enroll in another hospice in your service area, but that's considered a discharge. And then if you transferred to a different hospice, even though you were in the same service area. And that occasionally happens if there's some issues with the hospice.
But none of those were dementia.
That is overall. That's all players. I mean, that's all diseases.
Dementia would be even rarer.
I think say a little more about that if you would.
Well,
what you're asking.
You know, if you're in hospice because of your liver or your kidney or whatever, maybe they can do something to cure it. Mm-hmm. Even though you said you only go into hospice if it's not curable. Mm-hmm. But still, it could have been something that made you better or made you easier to take care of, that kind of thing, and you didn't need that anymore. Mm-hmm. But with dementia, it's just going to continue to get worse, isn't it?
It is. That's a great question, because when we're on hospice, and like we've said, dementia isn't always the terminal diagnosis. It's
right.
Maybe some of the comorbidities with it. So dementia, there may be cognitive decline in a patient, but if their physical decline does not progress, if their disease does not progress and they become stable or they may become a little bit better, that cognitive decline can continue, but we can't base anything on, we can't predict now there's not a 6-month life expectancy because either stabilization or gotten better. The beautiful thing about the Medicare hospice benefit is when you enroll, there's these certification periods you have to go through, or the patient goes through, that we look at the first 90 days of care, that we provide all the care to the patient, and at the end of that 90 days, we look how we done, how's the patient done, has there been continued decline, have there been some markers that there is still some disease progression, we can then recertify for another 90-day benefit. Provide all that care. Again, you know, at the end of that care, we do our work, we watch and see, and if there's still disease progression, we can recertify again for every 60 days after that. So those two 90-day benefit periods get you to that 6 months. And we say, okay, what has happened in these last 6 months? Sometimes it'll be that our staff say, there's nothing changing. And it's kind of difficult because when you have hospice care, you have all this care come in, somebody gets well managed, and they actually start to do better because there's some management about it. But if we can't determine and prove to Medicare that, you know, there's still disease progression, then we have to graduate or disenroll somebody. Yeah.
And sometimes we'll see people come from the hospital too. Maybe they had COVID or you know, something else. They were in the hospital for 10 days, which can make even a young, healthy person delirious. But with somebody with dementia, they're out of their familiar environment, and so they really, really decline while they're in the hospital. They come back on hospice, and they're being fed, but then all of a sudden again they can start just with finger foods, feeding themselves. They put the weight back on, they're back in their familiar environment, and they kind of get back up to their baseline.
Yeah. If you were to ask me what is the classic scenario of someone living with some kind of dementia that I graduate, it's typically the one that I'm optimizing the meds once they come on hospice, meaning we get rid of some of the meds. They actually sort of plateau, and they're in their 70s. For whatever reason, more often than not, it's like, oh, they're in their 70s. They just, now, it's a period of time where you're like, oh, how many months or years do they have left? And sometimes we re-enroll people 2 or 3 years later, and we're sort of shocked that they live that long. But yeah, I mean, there is this good tension between Medicare and a hospice agency, and we get audited, you know, and there are fraudulent hospices out there, no doubt about it as well. So you gotta play within the rules. You want to paint the picture of decline as best you can, and yet you live with what you have. And I think some of the rub, as is being said, is especially when you have like certain durable medical equipment, and you feel like there's all this support, and then hospice has to pull out and then the medical equipment has to be shifted to another medical company, and there's not always that great landing. It'd be great if you could just pivot from hospice and then transition into a community-based palliative care program. Some hospices, not necessarily in Minnesota, but in the East and West Coast or down south, they have hospice and they also have a palliative care program. And so you can hand them off to the palliative care program, you know, and then you can hand them back to the hospice when they start declining again. That's the sort of less common, unfortunately, right now than we'd like it to be.
And just to take on to that a little bit, when we graduate somebody or somebody is discharged, it's not hands off. It's not like we're walking away. We'll keep in touch with you or the facility or the care team and check in 2 weeks saying, how's everything going? Any changes? Or in a month? Anything changing? You know, we just want to make sure that we're available for you. And I forgot my other thought now.
While you're thinking of it, the other thing is it's not inappropriate, meaning it is appropriate to appeal the discharge. Mm-hmm. You have the right to appeal the discharge, that's the term, and then it goes to a third-party auditor that is in a certain region of the country. In Minnesota, it's actually, the auditor is in Minnesota as far as what they call the RAC audit, and they'll review all of the documentation that the hospice has been doing up to that point, especially with not recertifying you, meaning you're not eligible anymore, and they will decide if you appeal whether or not they agree with the hospice or they disagree with the hospice. As a hospice medical director, I welcome actually you appealing, because if I'm on the edge and I feel like I really can't keep you on or your loved one on, and yet the audit says we did the wrong thing, which then it helps protect us as a hospice from quote committing fraud. So I think the appeal process there's a turnaround within 48 hours after you decide to appeal to that hospice. They should not be taking that, personally or negatively. Actually, sometimes that can be helpful. And sometimes you win it, quote unquote. There's nothing to be won, but the point is we're trying to all discern if we can keep you or your loved one on. The other thing is, if you do appeal and it is upheld that the hospice seemingly has all the information, they've done the right thing to discharge you, you can go to another hospice and have them look at you again right after that, because they might have different data than what the other hospice did and what the auditor looked at from that hospice. So that's the challenge. I occasionally get people that have been just discharged, and I'm, that's red flags, right away. But I'm always open to reviewing it, because there might be some golden nuggets that the other hospice missed, and we can spin it away that will actually, within the realm of not fraud, will keep that person on hospice. So that's a little bit of the down and dirty behind the scenes. But again, it comes back to painting that picture of decline. So.
My father-in-law was on hospice for about 8 months and then graduated. And his first comment was, "What did I do wrong?" But he understood that he had plateaued. He really was not getting sicker anymore. He did not have dementia. But the hospice program kept in touch with us, and I can't remember what they called it. It's not an after hospice program. There was some kind of a bridge kind of thing program. And about 2 or 3 weeks later, he had a urinary blockage, needed to go to ER, and we called them, and they had a nurse who met us there at the ER so that they would not admit him, which had happened before when he went in just to get something, and not this is before hospice. He didn't intend to get admitted. He got admitted anyway, and didn't really need to be. But the default with the ER was, if we think there's a problem, we're going to admit him, and we'll discharge him tomorrow.
Yeah.
And this was very helpful. And he got readmitted into hospice after that. I mean, it was like 2 or 3 weeks. Readmitted immediately. And he died about 2 weeks after that. It was but the transition was, it's been 12 years. It's still, it was really important to us. It was really thoughtful, really caring, and it really respected him. It was just so wonderful. We had hospice with all 4 of our parents, and varying degrees of competence, I'd say. 2 of them were here in the Twin Cities, were perfect. 2 of them were in Western Wisconsin and was not so perfect. They were okay. One was fine, sort of okay, and the other was not so okay. But it was, so every experience is different. But our experience here was just wonderful. I tell that experience to anybody who has any questions about it, including my sister in Oregon was trying to get her 101-year-old father-in-law into hospice. He had fallen a number of times. He was getting really confused about stuff. He was not eating well, a whole bunch of things that really seemed to me to say, this guy, 101, probably he might die within 6 months. It's a possibility. But his physician would not admit him. It took him about 3 or 4 weeks before he had another fall. And I called the hospice. The hospice said, we're the only ones around here. You can't get anybody else, but you might try and find another physician, and that was a problem. Anyway, whole other issue. But the transition stuff was really important for us.
Yeah, I think that's important to families, knowing that we're not walking away. We're going to keep watch. Yeah. And I think the other point I was going to make, just to reiterate that, kind of what Jen said with dementia, that dementia can continue. When we're talking about discharge off of hospice with a patient with dementia, but their memory is getting worse and they're more confused. I know, but they're healthy. They're not in decline anymore. So those are tough conversations to have sometimes.
But we don't have a crystal ball. I wish I did sometimes.
Yeah.
And yet you have these acute changes in condition, and that's where hospice should be able to mobilize, because they're waiting they're waiting in the room, the waiting room, so to speak, at bay to get back in. So.
We have one more question before we open it up to the more audience questions. And that's around kind of how and when should you start having this discussion about hospice? When should you start talking to your doctor about it? When should you start talking to your loved one and with other family members?
Oh, it says I'm up first.
Yeah, Jen's first this time.
Okay. Again, with someone with dementia, there needs to be something else besides that dementia. So if you are noticing changes, falls, those ADLs, activity of daily life, before somebody able to use the spoon themselves, and now all of a sudden they're just using their fingers, or they're not even knowing what to do, and now you're feeding them. You're gonna look and notice those changes. That is if your loved one's living at home. If you're living in a facility, the site staff will start noticing those things. And for instance, like because Optage is a division of Presbyterian Homes, probably 70% of my clients live in a Presbyterian home site. Now, some might be in memory care, but some might have dementia and still be in assisted living or the care center, or even independent living sometimes with a spouse. So it kind of depends, but if they are in even an assisted living or memory care, the staff will start to notice those things too. They'll talk with the family, they'll talk with the hospice team that they typically work with. And then they might say to the family, or the family might say to them, we'd like to just take a look at hospice. You have your choice of hospices, and we are so fortunate in the Twin Cities. There are so many different good hospice organizations. So then you can interview 1 or 2 or 3 different hospices. You can just have a consult to look. That information about your loved one would be sent and reviewed to see if they were hospice appropriate or not. And if they weren't, you could get some more information on, here's the things we're going to be looking for when your loved one might qualify for hospice. So I think, talking with your doctor, if your loved one is at home, their doctor, or the site staff if they're in a facility. And then about talking with them too. I mean, depending upon their level of cognition, they might say, I hate the hospital, or, whatever the case may be, and just saying, would you like it if we set up care right here in your apartment, rather than you having to go back to the hospital if you have another fall, or rather than having to go back to the hospital if this is your circumstance? And if they say, yeah, I never want to go back there again, or you just can tell the whole time they're there, they're disoriented, their facial expression is grimaced, you can, at whatever level of cognition they're at, kind of explain to them, well, let's make sure you don't have to go back to the hospital again. Would that be important to you? They can tell you. And then with family members, a lot of times people are really, really scared. Kids, grandkids, family, friends, they hear the word hospice, and again they think, I didn't think Grandpa was going to die 2 weeks from today. Well, he's not. So really it's just kind of that education piece. And the hospice team is happy to do that too with family members. Just kind of getting people's mindset on, hey, hospice is just going to be helping our loved one live the fullest life that they can until this life ends.
That was really well said. I think the only thing I would add on is it's kind of like the discussion around advanced care directives. The earlier you have the conversations of the what ifs, the whens. It's not about predicting or looking at the demise or the end, but it's the what ifs and whens, and what do you want to be done about that, or what do you want me to do about that? And those honest conversations too is, when or if this happens, I'm not going to be the one to care for you. We have to talk about other plans. What if I can't? Then let's talk about some plans. So as soon as there's a chronic disease or something that's going to be life limiting, it's time to have those conversations just about the what ifs and whens. And then, to be honest, I might not be the person to be able to do this, but I am going to make sure that you're well taken care of.
Yeah, I think the when to start the discussion, the earlier the better. Sometimes it's planting seeds, it's getting information just so you begin to get normalized to this concept of in philosophy of care. But often when people are sick and tired of being sick and tired, or they don't want to be sent to the emergency room, they don't want to be rehospitalized. Those are really, for me as a clinician, like great opportunities, because I think we know people want to, if possible and appropriate, from what we've heard in a lot of the literature out there, is people want to die in their home, right? Unfortunately, we still know that doesn't always happen. Some people, more often than not, still die in the hospital on life support. And that's where the advanced care planning conversations come in. That's where being able to really have some guardrails around that support at home. Even though we're not on site 24/7, we're at a moment of call at 2 a.m. in the morning, where a hospice should be able to mobilize their hospice angels that are working at night and get them out to your home, in 30 minutes instead of calling the emergency room. Those are the types of things that you don't want to wait for the shoe to drop and then you're stuck in an emergency room, and those are taxing, obviously, to frail elderly as well as anybody. I mean, we don't want to have to be moved if we don't have to. So, yeah, I think the sick and tired and not wanting to be, moved. I think that sometimes people, they are terminal, and yet the thought is, well, let's move them to an assisted living, or let's move them to a nursing home. That may need to happen if you don't have enough care support, care provider, caregivers, care partners, as we like to call them, family and friends, along with hospice. But a lot of times the opportunity to also prevent that next transition to a higher level of care, such as from an assisted living to a nursing home, or from home to an assisted living, I think a lot of hospices take great pride in being able to keep you where you are and be able to live out your days as long as you have a terminal diagnosis, so that's what they're trying to do, at least.
In my family, both my wife's side and my side, we found ourselves with nobody in the family wanting to start the conversation, but everybody really wanted that conversation to go on. And so my wife and I have gotten into the habit where we pretty regularly, we talk about what will be the signs that say we need to move out of our house and do something else. And we talk about our advanced directives and if we need to update them and what we're thought about it, that is. We talk with other people too. And we also talk about what happens, what are going to be the markers that say, I need hospice care, and we each are giving each other permission to say, you need to be able to take care of yourself. So it's sort of that's a combination of hospice care, or maybe I need to be in a facility or whatever. But we're really trying to have that conversation. So it's a kind of a normal conversation already, long before, with any luck, long before we need it. And it's really easy for us to talk about that now, and it's getting easier for the rest of our family because we talk with them about it too. But the notion for me is now is the right time to start talking about all of these end of life kind of things. Especially when you get beyond age, but even middle age is not a bad time. I know a lawyer, a Minneapolis lawyer, who every Thanksgiving has gotten her family together, and now for probably 15 years, they talk about advanced directives and end of life stuff every Thanksgiving. And they all were really off-put the first couple of years, and then it's just part of family life now. So having those discussions about the hard stuff, the hard thing is just to start the conversation, it seems to be really, really important in my family anyway.
Advanced care directives, I think we would all just stand up and cheer for advanced care directives. There is, and you can order these online, something called Go Wish cards. So some of you are nodding, you've seen those. If you have somebody who really doesn't like to talk about things but likes to play cards, you can say, hey, we've got a new card game for you. But on every single card it says, like, I want to be in my own home, or I don't want to be on life support, or this or that. And you can narrow down, what's your top 15? Okay, now let's narrow that down to 10. Let's narrow that down to 5. And it's just a good way without just sitting. It's kind of a little more fun way to have those conversations around those cards.
Yeah, I'd plug that Go Wish, especially people that are male that don't like to talk. Not everybody, and people that have actually had, strokes or other conditions where they can't speak, but they can move and sort cards because they're in there. So something to keep in mind. Go Wish, yeah.
Yes.
So a couple questions about approaching hospice care. One is, it sounds like if you're a family, you've got a family member where you're thinking that hospice may be appropriate sometime in the relatively near future, keeping a log would be really important and really helpful. So my question is essentially, if a family does keep a log, what ought to be logged? Obviously weight is one, but I'm curious about the others. The other question I've got is, I was really struck by the comment about some organizations having the combination of hospice care and palliative care so that the transition can take place. It sounded like that's relatively rare. And what I'm wondering is it rare in the Twin Cities and Minnesota? Is it appropriate, if you're looking for a hospice care facility and organization, to deliberately try to go find an organization that does both, so that transition can be smoother if needed?
Yeah, that's a great question. And how we've kind of talked about it is, your larger healthcare organizations, your hospitals and things, will have kind of a palliative care department. The hard part is palliative care, like, we would love to do palliative care in the home, but it's not funded right now like hospice is. So that's the one key. The palliative care that is out there right now is, we say, it's a philosophy of care. It's when somebody goes and talks to somebody in the hospital saying, these hospitalizations aren't helping so much anymore. What we're doing isn't helping anymore. We have to maybe take a different approach and maybe start doing more comfort measures than these curatives that aren't always helping. So it's more of a talk and a philosophy of, what are we doing? Is this really helping anymore? There are very few palliative care programs in the Twin Cities, and like I said, it's usually the larger healthcare organizations that can fund them themselves, or maybe it's more of a state assistance program, people who are on state assistance or county assistance that would be able to exercise those right now.
Yeah, and I think most, reputable hospice organizations, when people do graduate, will have worked with the family. I mean, the graduation doesn't just happen overnight. We've talked with the family, we've pulled back some of the services other than nursing to see if that is making a difference for that person, just all of that team members surrounding them. And then we would let the family members know, or the loved ones, here's the things that you can be looking for, because we would love to work with you and your loved one again. At this time, there just haven't been enough declines. We'll check in with you, but also check in with us if you start seeing this. So it wouldn't be like, see ya. You definitely have, with any reputable hospice organization, still that foot in the door. So.
I'll answer your question directly, but I want to plug of all the things that the federal government does well or doesn't do well. If you're a veteran, you can have hospice and palliative care concurrently. That is just remarkable.
Yeah.
And So keep that in mind. So, you know, it doesn't, it's because we don't want to have that gap in the transition from palliative to hospice care. And so hospices can enroll veterans that are currently in palliative care, and they continue to get curative care, but they're in hospice, but they're a veteran. So that is something that's very unique in the United States as far as the veterans. So keep that in mind. But as far as the list, you know, cut and dry is ambulation. Are they walking? Are they mostly sitting? Are they using an assisted device like a cane or a walker or a wheelchair? Are they bedbound? So the ambulation is a helpful one, especially for people that are living with various types of dementia. Are they able to do all of their self-care on their own, or do they need assistance from someone occasionally? Do they need total assistance or moderate assistance? We mentioned the weight or the intake. And then are they, in the case of someone living with dementia, they're not going to be cognitively fully intact, but are they, you know, from time to time confused, or are they just totally out to lunch every day? You know, also specifically with Alzheimer's disease and the FAST score, the functional assessment staging to it, it gets down to the point of, are they incontinent of bowel? Are they incontinent of bladder? Are they able to dress themselves or not? How many words a day do they speak? Is it 5 to 6 words a day? Is it 1 word a day? Can they smile even? Can they even hold up their head? I mean, that's when you get very advanced. So, I mean, but bottom line is you get to the point where those are all, whether it's the palliative performance scale and or the FAST, the functional assessment for staging tool, those will give you what you need in that list. In addition to just overall, and I think, you know, what is their life like 6 months ago, and then what's their life like now, and how much more are you having to help them? So, yeah.
Thank you.
If I'm shopping for an agency, I want my husband to go to either Jennifer or Jim.
We'll arm wrestle.
Yeah.
Now I know that Jennifer is probably not for profit,
Same here. No.
and you're not for profit too.
Correct, non-profit.
Now, if my husband's at a facility that is not for profit, and they're the ones that are saying, I think we should look into hospice, that means they probably have a hospice program that they want him to sign up with. And maybe I shouldn't be prejudiced one way or another, but I am.
It's okay.
You know,
Thank you.
I agree with you.
That's a great question, and
Because Jim, will you send your people to,
oh, I have a list of hospices that I would refer to.
do you have that over here on the
No,
table?
I mean, as somebody's looking at, ideally, when somebody says, you know, we're looking at a hospice program, a healthcare professional needs to offer choice. A hospital or a facility can't say you need to use this hospice program. That's aside, because there are some hospice houses that do that they run their own hospice program. But most facilities that a person resides in needs to offer choice for hospice.
Okay.
They may have a preferred one, and that
Sure.
one you can look up. There's a brochure on the back from the Minnesota Hospice and Palliative Care Program that talks about how to choose a hospice, what questions to ask, and also how to look them up. There's a scorecard out there
Good,
online of looking up hospices.
good.
So you can go pretty much with any hospice that you choose to go with.
Okay. And they'll let them come in.
Well, and there's another aside. Assisted livings, just about any hospice program could go into an assisted living because that's a residence.
Right.
Skilled nursing facilities, the hospice has to have a contract. So they might only say, we only have 3 contracted hospices, so you have to go with those. My coworker in the back, that's his job is to talk to skilled nursing facilities saying, we have somebody who's on hospice, our hospice, we'd like to contract with you for this hospice care. So skilled nursing facilities, nursing homes, they have individual contracts, but that's also gray area. You can ask if somebody can come in and start a contract.
Is that usually a contract just for a specific person, or is that an overall contract with that facility so that they're part of the referral?
That's the next thing I was just going to touch on. Usually the skilled nursing facility says, we work with these 3 hospices, or 1 or 2, whatever it is.
Okay.
Sometimes what we'll do is if we are at a home and we're saying we need a higher level of care, you know, it's not working here at home, and you choose to go into a certain nursing home, we'll go and talk to that nursing home and say, will you do a one-time contract with us? You know, we want that continuity of care and continue the team and that sort of thing.
If I had somebody in hospice with one of you, and I'm really happy with that hospice, I would say, which facilities are you in so that I can choose one of those? Because if somebody's in hospice care, the chance of being there for all that long is not that great. Probably within 6 months that probably would be dead. But I'd rather, you know, in that case, the hospice care is a lot more important long term, whatever long term is, than the facility.
Yeah, that's another great question. And what I like to do is ask you to look and see. I mean, we want to look at areas. You know, you want to be in a geographical area. You want maybe a company of some sort, or so we'll kind of narrow it down to places that will have you go and look. And we want you to get the feel, to talk to people, to see the environment, to make that informed choice. It's hard for us to say, I wouldn't go there. If it's something blatant, we are certainly going to steer you away, but we want you to make the informed choice. We want you to go and see.
That's kind of related. There are nursing homes which I would not want to go to, and you probably know what some of those are. But you probably can't say to me, I wouldn't go to that nursing home.
Right.
But so it's kind of a word game, I guess, where you were sort of saying, here's some places we can recommend.
And places we have contracts with.
Yeah.
But it's more complicated because you're also dependent on whatever residential facility having a spot that you can move into when you need to do it, and so many of them do not.
Yeah, that's so true.
I've only come from the for-profit hospices, so and agnostic of which hospice agency, for me, being a hospice medical director, knowing that a hospice can deliver the experience and the quality that you're seeking, which is ultimately excellence in communication. Communication is so critically important. Excellence in the clinical acumen or the clinical ability of the medical director. I mean, not to be biased to say you want to ask that, is the medical director a certified hospice medical director? But if you have a certified hospice medical director versus the medical director, because there's added training that they get, not everybody is, and you can actually go on to it's called, the credential I have is Hospice Medical Director Certified, so HMDC. You'll be able to find out who in Minnesota or any state is HMDC certified, okay? It doesn't mean that is, but I think some of those people, you ask them, what's their general job outside of the hospice? Well, they work in nursing homes, or they work in assisted livings, or they're a vascular surgeon. You know, it might give you a tip-off that this is not always, and a lot of it is because the vascular surgeon is in the operating room. They cannot communicate with the nurse when they're in the operating room. Some of it comes back to communication. And then the last thing, besides the excellence in communication and excellence in the clinical, is the agility to be able to be present quickly when something changes. And the challenge, that is the logistical and the windshield type of challenge, is can we get there when we're needed, or can we be on the phone and that we're on our way when something has changed. And so I've found sometimes the for-profits, not to say that I'm biased, because I used to work at Benedictine as a not-for-profit or a nonprofit, is there's just a certain drivenness to provide that excellent experience. Not always with the for-profits, but especially the bigger hospices that maybe have a caseload of 400 residents versus a hospice that has a census on average of 50 or 60, doesn't necessarily mean that they're better if they're bigger. Sometimes bigger makes it more, there's less agility.
Yeah.
Not always, but that's what I've found. And that's why some of these for-profits have such a great opportunity against a, you pick your big health system, and they sometimes do a better job. Not always, but communication, clinical excellence, and the ability to pivot really quickly.
Is there a metric for agility? I mean, if you're looking and trying to rate a hospice,
Well,
we could just ask, are you guys agile?
there are surveys out there that you get survey results, and the survey results don't always spin the way you want either. But the survey results, just like Nursing Home Compare, for nursing homes, you can see what rating they get. The same exists for hospices. There's a Hospice Compare type of website. So, and you'll get surveyed, the loved one will get surveyed after the hospice, experience upon death, So that's at the end of the bereavement cycle, I believe. So that's almost like a year later. But yeah, I word of mouth probably is the best.
Right.
I mean, I think we know that.
Yeah.
So, what adaptations are available for people from different cultures who need hospice and palliative care, and may have very different perceptions of treatments or what any of this means? And we're sitting here, and everybody here is pink, and well, but that's the accent in Minnesota, but it's changing. So, can you address that at all?
We work really hard on that. We've seen an influx in our hospice program with a Spanish-speaking population, and we really needed to understand that culture. So we dug in research and speakers and educations about how to work best with the Hispanic culture. We've had a large Hmong population. That was a number of years ago. We've had to really dig into understanding the Hmong population and their culture, and how do they talk about death and dying, or not talk about death and dying. Somali population, we've had an increase in that population. So it's a kind of learn as you go. It's also learn. Our approach is, whichever family we're going into, teach me what I need to know to help you. It can be a pink family. Your family is going to be different than your family. So teach me how I can best work with you culturally, whatever areas. So it's kind of learn as you go, but definitely just a lot of research on understanding that population.
So, are there educational programs now to solicit people from different cultures to be trained in hospice and palliative care, so that you have coworkers who are fluent because they're part of those cultures, or not?
I don't know if there's anything
Like
specific out
yeah.
there. I think the Minnesota Hospice and Palliative Care
That's it.
pushes that, but it's up to the hospice to hire in that field.
And you don't generally work with community health workers who would be entrenched in particular cultural communities?
Oh, sometimes.
Or do you?
Yeah, sometimes.
And as far as spiritual care goes, again, Presbyterian Homes is a Christian organization, but we're not there to try and, shove Jesus down somebody's throat. We're going to meet people exactly where they're at. They obviously can choose not to have a chaplain either. Or it might be somebody who would, who is Jewish. And so I might just meet with them. They just moved here because their kids are in town. I can let them know about different synagogues, and I can help them establish the spiritual needs that would be helpful to them if they chose not to go, with our own chaplaincy. Or sometimes people say, oh, I met her, I liked her, and so then I will, I've taken classes at synagogues, and I'm not going to go in and pretend that I'm Jewish, but I would be able to pray with them and do things that are comfortable for them with they and their families' approval, or we can have an imam come in, or those types of things. And then we have people who are atheist or agnostic that will say, yeah, I'd like somebody just to explore things with. And again, we follow their lead. That I'm not there to tell them anything. I'm just there to walk alongside them wherever they're at.
Yeah, when I introduce spiritual care, I talk about it's not about spirituality or religion. It's really about the existential questions, the meaning of life, and the whys, and the things like that. And just to try to make meaning of things.
And do you allow people who are trained as death doulas to work with you? And if so, how does that work?
A couple of ways. There are death doulas out there where somebody can, is the right word, hire, but use a death doula with their loved one. We are in the process now of having our own death doulas in hospice, where they walk along, and that's really working more specifically with the patient, and a patient who can articulate things about, again, those existential questions. What are things that still need to be done and talked about? We're just starting that. It's been about a year now that we've had death doulas in some of our hospice sites.
And we did train some death doulas at Presbyterian homes, so they are available if somebody wants them.
I'll say a couple comments. Maybe first on the death doula. So the only experience I've had with death doulas are ones that have been willing to volunteer for the hospice because of them not, sadly, not being usually, unlike perhaps what you're trying to do or doing, they're actually a part of the interdisciplinary team. I mean, they're part of the interdisciplinary team, but they don't necessarily get paid by the hospice to do that. So I think it is mostly a private pay type of thing. Just like if you had a doula for birthing, and I think the other thing is that does suggest that there is a gap, obviously, in the healthcare profession, either in their fund of knowledge, their bedside abilities, and yet also the amount of time or lack thereof, mostly, that even the RN or the nurse care manager has when they're having to deal with a lot of people that are all at different points in their hospice journey. And if 2 or 3 of them are actively dying, what do you do? And so I think that does help fill in those gaps. It evens things out, and yet, it unfortunately it seems to be more of a private pay type of situation based on the family or the person that's in hospice themselves. But I'm very, very supportive of that. And then I just on the topic of at least specifically on race versus the spirituality component. This is the data from 2021. Of the Medicare population who use hospice by race, 50% were white, 36% were Asian American, 35% were black, 34% were Hispanic, and 33% were North American native. So obviously there are inequities, there are disparities. Easy for me to say as a white male, and yet also the great opportunity even for hospices to be developed. Either they're focusing on that population, or at least they're able to recruit aides, health aides, or hospice aides, nurses, to be part of a hospice, even though perhaps the majority of the people are white. And there's no doubt about it, just that for whatever reason helps bridge the gap from the beginning and build better trust maybe up front, even though trust can be developed over time. So it is a continued challenge. And even with palliative care is even worse as far as the disparities and inequities, in part because of the funding source, and then also because of everything comes back, unfortunately, often to the primary care clinic, which is in a crisis in and of itself. Primary care is not what it used to be. So a lot of challenges with the healthcare system overall, but to at least be acknowledging of that, I think, is a step forward. And also, you know, the various language, I'm not talking different, whether it's Spanish or Russian or something, but just the terms, the terminology that is used to convey, and some people misunderstanding what the person is saying within that cultural tradition.
Are there any hospices that really are Somali or Hmong, or I know there's a funeral home that really does a lot of Hmong stuff in St. Paul. I don't know if are there any hospices that are really specializing in that, you know, in specific communities like that?
Not that I'm familiar with.
Yeah, and in many cultures, hospice just wouldn't even be something you would consider, because
Right.
you've
You
got
got families.
multi-generational
Yes.
families,
Right.
and so you're going to be caring for your loved one
Yeah.
right in your home.
Yeah.
Although you still, I mean, having medical stuff and other stuff too that could sort of supplement
Mhm.
the family can be helpful in that case.
Absolutely. I mean, that's probably where you have a lot of care partners and
Right.
caregivers,
Right.
Right.
just to have that one aspect of the
Yes.
hospice experience. And
We have a question over here.
We did more about dementia and hospice in particular. So it seems to me that a lot of folks living with dementia just do never ever take advantage of the hospice benefit, even though we know that it's coming. What is there, and it seems from, like, maybe this is more for Dr. B, when you're admitting someone to hospice, the criteria is somewhat objective or subjective and gray. Is there sort of a slam dunk, like they're at their fast score 7, that is when we should really be steering people in the direction? Is there kind of one or two kind
there
of golden
is,
things?
yeah, there is.
Okay.
The challenge is they're often not there yet, or they're so far there. But PPS of 30,
Okay.
so PPS, palliative performance scale of 30%, and then a FAST of 7A. So if I hear a PPS of 30 and a FAST of 7A, and they've had some weight loss, that is pretty much a slam dunk of enrollment. You can go on, I think a lot of hospices, they will have the eligibility criteria. There's actually a book that is given to many hospice medical directors that is all of the eligibility requirements. But the way you should look at it is, it's either they're a perfect fit, I mean they hit all of these eligibility requirements, they're a close fit, but there is some decline, they're a close fit and there's rapid decline, or they're not a fit, but it's the decision and the clinical judgment of the medical director. So there's really 4 ways you can get into hospice when you're using eligibility criteria. Perfect fit, partial fit, some decline or rapid decline, or it's just clinical judgment, And I mean, at the time, we didn't have a COVID-19 terminal eligibility. There's no eligibility requirements for COVID-19. That was really sort of pretty much, they're actively dying, or, we don't have any treatment for them, and we can judge that is clinically likely going to happen, more likely than not. So, but there are, and I think certain hospices, or a lot of hospices will have that. There might even be over there. I mean, there's criteria that are easily accessible. If you just were to go on and type in hospice eligibility for congestive heart failure, or hospice eligibility for liver disease, but those are the types of things I would look for.
Both with dementia, but just generally, do most families wait longer than they should in order to initiate hospice care?
I don't know about most anymore. I would say it's.
They're getting better.
Yeah,
It
I
is.
think it's getting better. The word is getting out. I think the facilities all have hospice programs they work with, and I think so. There's more conversations about what
Good.
Personnel are seeing. It's over my years, it's gotten much better.
Good, glad to hear that.
And the only thing I'd say to that is, getting back to data, so the average length of stay, the average is, as of 2021, 92 days.
92?
92 days.
Wow.
However, that's taking every single enrollee,
Yeah.
adding up all those days, and then dividing by the number of enrollees. The median, so the middle number of all of those is only 17 days.
Okay.
So when the
Yeah.
the median is much lower than the average, there's still a challenge or an opportunity.
Right.
Right.
Yeah.
But I would say those with dementia and probably congestive heart failure, things that happen very slowly, oftentimes will be on closer to a year than a month.
Do you have
know?
that one graph that shows the difference? I think that's just something that would play in really nicely. Or maybe, yeah, that one. Yeah, we didn't really talk about that. But that, essentially the green, so the x-axis of the bottom is the amount of time over many, many months or years of the individual, and then the y-axis, which is their functional status. So you see these different types of patterns. And let's just look at the blue, cancer. So usually what you see is what we will call a compressed comorbidity, which is you get diagnosed, prior to that you're doing pretty darn well, and then it's a fairly short time. Now every cancer is different though, right? So some cancers you're dead in 3 or 6 months, like oftentimes pancreatic cancer. And then you have the type of conditions like congestive heart failure, chronic obstructive pulmonary disease, that are these, you get rescued, you get better, but you never quite get as good as you were before, and that's that red dotted line. So you have that, it's just a cycle of, rescue, stability, and that's where you're often hospitalized or have ER visits. And then the green line is often that dementia type of diagnosis. So you can see it's much slower often, unless they have on top of that, a congestive heart failure diagnosis or a chronic obstructive pulmonary disease diagnosis or a cancer diagnosis. But that, I think, helps, or the sudden decline. I mean, you're dead within hours or days. So those are the things we all have to try to figure out, is where are you at with regard to that trajectory. And that's why painting the picture of the decline is so critical, because that helps us figure out where you are in that pattern. Yeah. I think the one other thing I'll say is with regard, I know this is one question that I get from time to time, is people that are on dialysis, hemodialysis, right? You have end-stage kidney disease, you're on dialysis, either peritoneal dialysis or hemodialysis, meaning you're going to a dialysis center versus you're doing it in your abdomen. Some people, remarkably, are able to do that at home. So do they qualify for hospice? Well, there's 2 parts to that. And if the hospice doesn't even talk about the 2 parts, then they probably don't know what they're talking about, at least within this area, because it is questionable. If I hear someone is on dialysis and they want to stop dialysis, that's a slam dunk. I mean, more often than not, because they will die probably within 3 weeks being off dialysis. And that's usually because of the electrolyte disturbance, and they may suddenly die. If the person doesn't want to get off dialysis for a few weeks because they want to get to their granddaughter's graduation, they may very well be able to enroll in hospice while they're still getting dialysis. And that hospice may be willing to pay, because they get paid per day for that individual. They may be willing to pay for that while there's an end date though, there's sort of a timeline. The other option is you're on dialysis, and yet you have the dialysis being a secondary diagnosis. So the primary diagnosis could be that you're living with colon cancer, and the colon cancer is going to kill you in 6 months, but in the meantime you're also on dialysis. Not a good mix, but if that is a secondary diagnosis, you can continue to actually do the dialysis and the hospice won't have to pay for it, and Medicare will pay for it. So they'll pay for hospice and they'll pay for the dialysis. It's a rare thing because a lot of times they're intertwined, but those are the scenarios where you can actually enroll in hospice and you're still on dialysis because you have an end date when you're going to transition off, or that it's a secondary diagnosis. So
We probably have time for one more question. Does anyone else have a question?
I've loved these questions, haven't
Yeah,
you?
I know.
This has been a
Fantastic.
really
Always
a
learn.
good discussion. I'm glad we had you three here, and the three different areas really coming together over this. This has been really fascinating. I knew a lot about hospice, but I learned a lot more today, so
Good.
it was good.
Would you two like, or would the three of you like to take a moment and give any parting advice or
Well,
anything?
I know one question we had all talked about was, how does hospice work with people with dementia? And we, that was, one thing that had come up. And obviously, Lewy body dementia is different than Alzheimer's, is different than frontal lobe. So it's really about finding out exactly how that person's functioning. Do they have hallucinations? Do they have sundowning? Is morning a better time to visit? So when someone comes onto hospice with dementia, we're not gonna just treat everybody the same. We're gonna look at that individual and exactly what type of dementia they have, what type of symptoms they have, what the best approaches are for them. If they're in a facility, we're gonna work with that facility and find out what works best for them. If they're at a home, and obviously we work with the family too to find out what's best for them, but we're gonna approach each different type of dementia with its own care based on that own individual, because even two people with Alzheimer's might have completely different things. So just rest assured that the individual needs would be met.
Yeah, and I think I would add on that we talk a lot about the person with dementia, and hospice care is about hospice care for the family, for the caregiver, and I mean family, extended family. Now in my work in bereavement, many times before, my work is mainly after death happens, but many times before I'll be called out to work with young children, call a son that's in California, spend some time with the wife while the husband's at a daycare or something, that our focus is to ensure that that person has that quality of life, but all of you have to accept what's going on, and we get to be there to ask those tough questions as, how is this going? Where is your grief? Where are you suffering? And what can we do to alleviate that? And those tough questions, I'm seeing changes, and are we able to stay here? That's our job, is to have those necessary and tough conversations in the most gentle way, because like I said, we're doing this all the time. Our approach is, this is your first time, and you have to teach me how you want to go, how you want to work through this.
I would just say that, I think all of us as healthcare professionals go into this type of work for the right reasons, which is to provide support and comfort, whether it's in the palliative care experience or the end of life experience of hospice care. And to have that synergy happen is very fulfilling for the healthcare professional, as well as the patient and their families. So it is reciprocal, and I think sometimes that doesn't always get mentioned, but it can be very fulfilling for everybody, even in a very challenging and maybe even dark time.
Yeah, and I think that's the other important thing to say. We're talking about death and dying, which can be very dark, but that time can be so beautiful at the same time, because it is celebrating a life, and that's the way we all approach it. We are doing a life review. We are celebrating this life that's about to end, and what does that mean for everybody that's involved? It's a joyous place to work. It's hard. I'm not going to say it's not difficult. It's sometimes very difficult, but it's a very joyous place to be.
With that, thanks for coming, everybody. I hope that you found it rewarding, valuable, beneficial, and please look at our future programs. Sarah's holding up flyers. We have almost one a month for the rest of the year, so check those out and visit our website. We also have information about Ecumen, Link Bloomston, and Presbyterian Homes over on this table. Thank you.
Thank you.